going to try to keep this right around the 3-minute mark. Okay. So poor postoperative urinary retention. It affects the micturition reflex in the first 3 days after any surgery. About a third of our patients are surgical, so this is relevant because the following people are at risk. 38% of those with cervical and lumbar spine procedures, those on beta blockers prior to surgery, males, people over 60, people with pre-existing conditions like BPH, and those placed on normal saline versus lactated ringers post-op. That's according to the folks over at the Allegheny University Hospital. So this blurb will specifically address the issue of GD versus RD, gradual drainage versus rapid drainage. Most often we think of the risks related to catheterization being things like UTIs or trauma related to insertion, patient discomfort. Now, RD, rapid drainage, carries the risk of rapid hypotension, especially in those patients retaining 1,000 mils or more. The thought is that if you drain the urine too rapidly on a straight cath or temporary indwelling, it could cause decompression. This is when the pressure of the urine draining too quickly draws the blood to that area, taking it from the vital organs. The trouble with that is that a lot of our patients are already at risk for low blood pressures because of those strong narcotics given in the postoperative period. Gradual drainage is when you drain 200 to 300 milliliters at a time, 2 to 3 hours apart, to reduce that risk of the hypotension. And that's more likely to happen when it's 800 plus mils of urine. When the bladder is stretched over about 600 milliliters, the rugae begin to stretch out, and that can contribute to some nerve damage. Also, when stretched too far, the patient might need to begin bladder training afterwards. Directly after draining, the bladder doesn't snap right back to its original size. This means that the patient could very well store, say, 500 milliliters before they even feel like they have the urge to void, leaving them likely unable to void completely. Now, in a medical journal by the Surgical Neurology International, they found that a study of 137 patients, just under 40% ended up retaining at least 250 milliliters in their first through third voids after surgery. That shows you how prevalent this issue is. Now, limited research is available, but I did find 4 or 5 studies that directly talk about draining more than 1,000 milliliters of urine at a time, and they'll come up with about the same answer. Few, if any, patients showed a difference in blood pressure, and most of those patients whose blood pressure did drop, the blood pressure drop was attributed to the relief of the full bladder. Of the physicians I've spoke with on the matter, some seem very concerned about the issue of hypotension, whereas others have never even heard of taking this precaution of draining or clamping a catheter at 1,000 mils. So I would say err on the side of caution with these patients. Don't drain more than 1,000 milliliters at a time, and contact your physician for further action. Close enough?